Welcome to the Deep Dive. We're here to unpack complex topics, pulling insights directly from the source material. Today, we're tackling the brain, an organ that's, well, surprisingly delicate on its own.
Oh, absolutely. It's quite amazing, really. If you were to just take the brain out without all its supporting structures, the bone, membranes, fluid, it would just be, well, a shapeless blob. It can't even support its own weight.
Right, it needs this whole elaborate setup just to exist.
Exactly. It relies entirely on this incredibly sophisticated environment.
And that dependency, that whole supportive environment, that's what we're diving into today. Our mission is to guide you, layer by layer, through everything that keeps the brain safe and functioning. We'll start with the hard outer shell, then move into the membranes, the fluids, the blood supply.
And critically, what happens when things go wrong,
Yeah.
when that system fails?
Yeah. So we're looking at the skull, the meninges, CSF, circulation, even the nerves that pass through.
And you can think of this whole system as juggling three main jobs simultaneously. First, obviously, protection. Physical protection from bumps and knocks. That's the skull's main role.
The bony fortress.
The bony fortress, exactly. Second, constant nourishment, and just as important, waste removal. That's the vascular system, the blood vessels working with the meninges.
Keeping it fed and clean.
Pretty much. And third, mechanical suspension, keeping it from banging around, cushioning against gravity and movement. And that's
Right.
largely the job of cerebrospinal fluid, the CSF, and again, the meninges acting like internal straps.
Okay, so let's start on the outside and work our way in. The first line of defense.
Mm.
The skull, the cranium.
Right, the bony fortress. It's really an evolutionary masterpiece. It's incredibly rigid, obviously, but also has points designed for a tiny bit of give, especially during development.
Yeah.
Functionally, we tend to split it into two main parts.
Okay.
There's the neurocranium, which is basically the collection of bones that form the vault directly enclosing the brain, the skull cap part. And then there's the viscerocranium. That's the framework of the faces, jawbones, cheekbones, nasal bones, all that stuff.
So for protecting the brain itself, we're mainly interested in the neurocranium.
Correct. And within the neurocranium, you've got a mix of bones. Some are paired, like the parietal bones on the sides, the temporal bones near your temples. They're mirror images,
Symmetrical.
mostly, yeah.
Yeah.
But then you have several really crucial unpaired bones, often sitting deeper inside the skull.
And these unpaired ones, the sources suggest, are kind of anatomically fascinating.
They really are. They're often complex shapes and hold key structures together. Let's take the ethmoid bone first. It's a single, unpaired bone tucked away deep in the front part of the skull. You can't easily see it from the outside.
But it does a really important job, right? It's like a partition.
Exactly. It's the boundary wall between the brain cavity and the nasal cavity below it. It forms the roof of your nose, sits right between your eye sockets.
And structurally.
Structurally, well, it's surprisingly delicate, quite fragile and porous, full of little air cells. It includes a key structure called the cribriform plate.
Ah, the sieve-like part.
Yeah, cribriform means sieve-like. It's got tiny holes that allow the olfactory nerve fibers, the ones for smell, to pass up from the nasal lining directly into the brain.
And this porosity is where that interesting detail about other animals comes in, something about iron.
That's the really cool part. In some migratory animals, like birds or fish, similar porous bones in this area have been found to contain tiny crystals of magnetite iron ore.
Wow.
And the theory is that this might be linked to their ability to sense the Earth's magnetic field, for navigation, a sort of built-in compass.
Is that the case in humans?
Well, it's not really established as a functional magnetic sense in humans,
Yeah.
but the similar structure is there, which is, just a fascinating hint at maybe a shared evolutionary past or a remnant function. It's intriguing.
And it connects to a lot of other bones, too.
Oh, yeah. The ethmoid is a busy intersection. It articulates with something like 13 other bones, including the big frontal bone and another really important internal bone, the sphenoid.
Okay, let's talk about the sphenoid bone. The sources often describe it quite visually, the bat bone.
Yeah, or sometimes a butterfly. It's another unpaired bone, mostly internal, though you can see little bits of its wings on the sides of the skull near the temples. But its real importance is internal. It's often called the keystone of the cranial base.
Keystone, meaning it holds everything else together.
Pretty much.
Yeah.
It sits centrally and connects to almost all the other cranial bones. It's like the central locking piece that provides stability to the whole structure. Its shape, with those wing-like projections, allows it to brace everything.
But its clinical fame really comes down to one specific feature, doesn't it? A little depression inside?
You're thinking of the sella turcica. It means Turkish saddle in Latin.
Right.
And it's this saddle-shaped depression right in the body of the sphenoid bone. And its crucial job is to cradle and protect the pituitary gland,
The master gland.
the master gland of the endocrine system, controlling hormones throughout the body. So the sphenoid isn't just structural. It's actively protecting this vital hormonal control center. Neurosurgeons often access the pituitary through the nose, going via the sphenoid sinus. Its location is a key landmark.
Incredible. Just one bone doing so much. Okay, before we leave the bones, the outline mentioned a couple of others, specifically the vomer and the ear ossicles.
Right. The vomer isn't part of the neurocranium. It's technically viscerocranium facial bones. It's a small, thin bone shaped a bit like a plowshare,
Okay,
and it sits right in the midline of the nasal cavity, forming the lower part of the nasal septum, the wall that divides your nose into left and right halves.
got it. And the ear ossicles, they're listed under the neurocranium.
Yeah, technically they are included because they live inside cavities within the temporal bone, which is part of the neurocranium. We're talking about the malleus hammer, C-fin anvils, and stapes stirrup.
The tiniest bones in the body.
The tiniest,
Hmm.
especially the stapes. It's minuscule. Their job is purely mechanical, transmitting sound vibrations from the eardrum across the middle ear to the inner ear. It's incredible leverage and amplification packed into that tiny space, all protected within the temporal bone.
Amazing engineering. So that covers the main bones. But this fortress isn't solid. It has openings, right, for nerves and blood vessels, the foramina.
Absolutely. The base of the skull is riddled with these openings, these foramina. Each one is a specific pathway. The most obvious, of course, is the huge foramen magnum at the very bottom.
Where the spinal cord connects.
Exactly, where the brainstem transitions into the spinal cord. But there are many others, like the carotid canal, a tunnel for the internal carotid artery to bring blood into the brain, and the jugular foramen, a larger opening for the internal jugular vein to drain blood out.
And you mentioned some paired holes in that central sphenoid bone earlier.
Yes, crucial ones. The foramen spinosum and the foramen ovale. They're important landmarks, especially in surgery. The foramen spinosum is particularly relevant because it's the entry point for a key artery called the middle meningeal artery.
And we'll probably come back to that artery later.
We definitely will, especially when we talk about certain types of head injuries and bleeding.
Okay. So that's the rigid bone structure. But as you said, the brain isn't just rattling around inside. It's suspended, cushioned, damped. Let's move inward, past the bone to the next layers, starting just outside the bone first, the scalp.
Right. Before you even get to the skull bone, you have the scalp layers. There's the skin, then dense connective tissue, then a tough fibrous layer called the galea aponeurotica,
Okay.
then a layer of loose areolar tissue. This is the danger zone where scalp infections can spread easily. And finally, the periosteum, which is the membrane directly covering the outer surface of the skull bone. People sometimes use the mnemonic SKLP for those layers.
Skin, connective tissue, aponeurotica, loose tissue, periosteum. Got it. Okay, now we cross the bone barrier. Inside the skull, what's the first thing we hit?
The meninges. These are the three protective membranes that wrap the entire brain and spinal cord.
The three layers we often hear about.
Exactly. Traditionally, they're grouped. You have the pachymeninx patchy, meaning thick, which is just the outermost layer, the dura mater. And then the leptomeninges lepto, meaning thin, which are the two inner layers, the arachnoid mater and the pia mater.
Let's start with the tough one, the dura mater. Tough mother, right?
That's the literal translation. And it fits. It's by far the thickest, strongest, most durable layer. It lines the entire inside surface of the skull. Now, a key point is that inside the skull, the dura actually consists of two layers that are mostly fused together.
Two layers.
Yeah. There's an outer periosteal layer, which basically acts like the inner periosteum for the skull bones, stuck right to the bone. And then there's an inner meningeal layer, which is the true meningeal dura.
And why is it important that there are two layers? Do they separate anywhere?
They do. In certain specific locations, these two dural layers separate to form channels or sinuses. These are the dural venous sinuses.
Ah, like the big superior sagittal sinus that runs along the top midline.
Precisely that one. And others like the transverse sinuses. These aren't veins in the typical sense. They're more like large endothelium-lined drainage canals contained within the dura itself. Their job is to collect all the deoxygenated venous blood draining from the brain tissue.
And where does that blood go?
It all funnels down, eventually draining out of the skull, primarily through that jugular foramen we mentioned, into the large internal jugular veins in the neck. It's the main outflow plumbing for the brain's blood.
Okay. Now, something our sources highlighted about the dura is surprising. It feels pain. The brain itself doesn't, but this covering does?
It's a really critical clinical point.
Yeah.
Unlike the brain tissue itself, the dura mater is richly supplied with sensory nerve endings, mostly from the trigeminal nerve, cranial nerve V.
So when the dura is stretched or irritated,
It hurts. This explains many types of headaches. Things that distort the dura, inflammation, blood, a tumor pushing on it, even changes in CSF pressure pulling on it trigger these nerve endings. That's the sensation of a headache.
fascinating. Okay, moving inward from the tough dura. Next layer.
Next is the arachnoid mater, the spiderweb mother.
Why spider web?
Partly because it's a much thinner, more delicate, almost translucent membrane compared to the dura. It doesn't adhere directly to the dura. There's a potential space, the subdural space. But functionally, it's incredibly important. It's a vascular, no blood vessels of its own.
And its main job.
One key role is acting as a barrier. The cells of the arachnoid mater are joined by very tight junctions, forming a seal. This prevents the cerebrospinal fluid, CSF, underneath it from just leaking out into the dural layers. It keeps the CSF contained in its own space.
So it holds the fluid in and the web part. Does that relate to structure?
Yes, exactly.
Yeah.
Extending down from the underside of the arachnoid membrane are numerous fine web-like strands of connective tissue. These are called arachnoid trabeculae. These trabeculae span across the space below and attach to the innermost layer, the pia mater. Think of them like tiny suspension cables or guy wires. They help physically suspend the brain within the fluid-filled space, adding mechanical support.
So it's not just floating freely, it's also tethered by this web.
Precisely. It's a combination of buoyancy from the fluid and this web-like suspension system.
Okay, and the final innermost layer.
That's the pia mater, the tender mother. And we really use tender, extremely thin and delicate. Its defining feature is that it adheres directly to the surface of the brain and spinal cord.
Like cling film.
That's a great analogy.
Ah.
It follows every single contour, dipping into every groove, sulcus, and folding over every ridge, gyrus. It's intimately connected to the brain tissue itself. Tiny blood vessels actually perforate the pia to enter the brain.
So we have dura, tough outer, arachnoid, web-like barrier, and pia, thin inner lining. What about the space between the arachnoid and the pia?
That's a critical space. The subarachnoid space.
Right.
Sub meaning below the arachnoid. This is the space that contains those arachnoid trabeculae, but more importantly, it's completely filled with cerebrospinal fluid, CSF.
Ah, so that's where the CSF lives.
That's its primary location around the brain. All the major cerebral arteries and veins also travel within this subarachnoid space, bathed in CSF before they dive into or emerge from the brain tissue via the pia.
And you mentioned CSF needs to be drained. Does that happen here too?
Yes. The CSF is constantly produced, circulates through the ventricles in this subarachnoid space, and then needs to be reabsorbed back into the bloodstream. This reabsorption happens primarily through specialized structures called arachnoid villi, or granulations.
Okay.
These are little protrusions of the arachnoid mater that actually poke through the meningeal dura and into those large dural venous sinuses we talked about earlier.
So they connect the CSF space directly to the venous blood.
Exactly. They act like one-way valves. When CSF pressure is higher than the pressure in the venous sinus, the valves open and CSF flows out into the blood. When venous pressure is higher, they collapse, preventing blood from refluxing into the CSF space. It's a pressure-driven drainage system.
This whole fluid suspension system sounds crucial for protecting the brain's physical structure.
It's absolutely fundamental. The buoyancy provided by the CSF is incredible. An average adult brain weighs around 1,500 grams, maybe 3 pounds or so.
Feels heavy if you hold one, I imagine.
Right. But floating in the CSF bath inside the skull, its effective weight is reduced to less than 50 grams.
50 grams. From 1,500, that's like a 97% reduction?
Exactly. It's almost weightless in situ. This massive reduction in effective weight is what protects the brain from distorting under its own weight and, crucially, dampens the forces during movement acceleration, deceleration, rotation. Without it, even nodding your head could potentially cause shearing injuries to the delicate brain tissue and nerve tracts.
Wow. Okay. So the meninges aren't just linings. They also form internal structures. The outline mentioned dural folds or shelves.
Yes. The dura mater doesn't just line the skull cap.
Yeah.
It also folds inward in certain places, forming tough, sheet-like partitions that divide the cranial cavity into compartments. These are formed by the intermeningeal layer of the dura folding in on itself.
And what are the main ones?
There are two major ones. First, the falx cerebri. Falx means sickle-shaped. This is a large vertical C-shaped sheet that dips down into the longitudinal fissure, the deep groove separating the left and right cerebral hemispheres.
So it partly separates the two halves of the main brain?
It does. It doesn't go all the way down, but it provides significant compartmentalization between the hemispheres, limiting side-to-side movement.
And the second one?
The tentorium cerebelli. Tentorium means tent. This is a large horizontal sheet of dura stretched across the back of the cranial cavity, forming a sort of roof over the cerebellum, which sits underneath it.
Okay, a roof over the cerebellum, what does that separate?
It separates the posterior cranial fossa, containing the cerebellum and brainstem, from the rest of the cranial cavity above. So it divides the whole space into the supratentorial compartment, containing the large cerebral hemispheres, and the infratentorial compartment, containing the cerebellum and brainstem.
And there must be an opening in this tent for the brainstem to pass through.
Absolutely. There's an oval opening in the front part of the tentorium, called the tentorial notch or incisura. The midbrain passes up through this notch to connect the brainstem below with the cerebrum above.
These dural folds sound important for stability, keeping things in their place.
They are. They help limit excessive movement and provide internal bracing. But their rigidity is also a double-edged sword. Because they don't move, they become critical boundaries when things go wrong inside the skull.
Which leads us nicely into the next big topic, intracranial dynamics. Pressure, volume, and what happens in a crisis.
Precisely. Because the skull is a rigid box, and those dural partitions are also fairly rigid, the contents inside are subject to a fundamental principle known as the Monro-Kelly doctrine, or hypothesis.
Okay, Monro-Kelly, sounds important. What's the core idea?
It's actually quite straightforward physics. The doctrine states that the total volume inside the rigid cranial vault is essentially fixed. And that volume is filled by three main things, none of which can really be compressed: brain tissue itself, cerebrospinal fluid, CSF, and the blood volume within the cerebral vessels.
Brain, CSF, blood, fixed total volume.
Right. So the critical implication is this. If you add something else to that fixed space, say a growing tumor or swelling edema, or a collection of blood from a hemorrhage, the volume of one or more of the original three components must decrease to make room. If it doesn't, the pressure inside the skull inevitably goes up.
Something's got to give.
Something's got to give. Initially, the body has some compensatory mechanisms. The easiest things to displace are the fluids. CSF can be shunted out of the cranial halt down into the spinal subarachnoid space.
Okay, squeeze out some CSF.
And also, the volume of venous blood in the dural sinuses and cerebral veins can be reduced slightly by increasing drainage. These happen pretty quickly.
But there's a limit to how much CSF and venous blood you can push out.
Absolutely. These are relatively small volumes. Once you've maxed out those initial compensations, if the extra volume, the tumor, the bleed, the swelling continues to increase, then the intracranial pressure, ICP, starts to rise. And it doesn't just rise linearly, it often rises exponentially.
Oh, okay, that sounds bad. Why is high ICP so dangerous?
Because it directly threatens the brain's blood supply. We need to think about something called cerebral perfusion pressure, or CPP.
Perfusion pressure. The
Yeah.
pressure driving blood into the brain.
Exactly. CPP is the effective pressure gradient that pushes oxygenated arterial blood through the brain tissue. It's calculated quite simply. CPP is your mean arterial pressure, MAP, your average systemic blood pressure minus your intracranial pressure, ICP. So CPP equals MAP ICP. Okay, MAP minus ICP.
Think of MAP as the pressure pushing blood in, and ICP as the pressure pushing back from inside the skull. The difference is the net pressure driving flow.
So if your ICP starts to rise sharply,
And your MAP stays the same, your CPP drops. If CPP falls too low, blood flow to the brain decreases. The brain becomes ischemic, starved of oxygen and glucose.
and that leads to brain damage.
And rapidly. The brain absolutely depends on continuous, adequate blood flow. Maintaining CPP within a safe range is critical for survival.
Does the brain have ways to protect its blood flow if, say, our general blood pressure changes?
Yes, it does. It has a remarkable ability called cerebral autoregulation.
Autoregulation. It regulates itself.
Kind of, yeah. The brain, as we said, is incredibly greedy metabolically, but also very picky. It doesn't like too much flow or too little flow. Autoregulation is the intrinsic ability of the cerebral blood vessels to adjust their diameter to keep cerebral blood flow, CBF, constant, even if the systemic blood pressure, MAP, fluctuates.
So if my blood pressure goes up, my brain vessels constrict. And if it drops, they dilate.
Exactly that. Within limits, of course. There's a specific range of mean arterial pressure over which autoregulation works effectively. Typically, this range is somewhere between about 50 mmHg and 150 mmHg of MAP.
Okay, 50 to 150.
Within that range, if MAP goes up, stretch receptors in the vessel walls trigger vasoconstriction to prevent excessive flow and pressure. If MEP drops, the vessels dilate to maximize the flow it can get. It's trying to keep CBF stable.
What happens if MAP goes outside that range, below 50 or above 150?
Then autoregulation fails.
Yeah.
Below an MAP of about 50, the vessels are already maximally dilated. They can't open any further. So below that point, CBF becomes passively dependent on pressure. If MEP drops further, CBF drops dangerously low, risking ischemia.
And above 150?
Above an MAP of about 150, the constriction mechanism is overwhelmed. The vessels start to be forced open by the high pressure. This can lead to breakthrough hyperperfusion, potentially causing fluid leakage, cerebral edema, or even rupture of small vessels.
So the brain fights hard to stay within that sweet spot.
It does. But remember, this is all complicated by ICP. If ICP is very high, even a normal MAP might not be enough to generate adequate CPP.
Right, CPP equals MAP, ICP. So when ICP starts to climb dangerously, what signs should we look for, besides the headache from dural stretch?
As ICP rises and starts to impair brain function, we see escalating neurological signs. Altered mental status is a big one. Initially, maybe just irritability or confusion, but progressing to lethargy, stupor, or coma as cerebral function or brainstem alertness centers are compromised.
Okay, what else?
Nausea and vomiting are common, often quite sudden and forceful, sometimes called projectile vomiting. This is thought to be due to direct pressure on vomiting centers in the brainstem.
That sounds serious.
It is, but the really ominous late sign that indicates critical levels of ICP and failing compensation is something called Cushing's triad.
Cushing's triad, named after Harvey Cushing, the neurosurgeon.
That's the one. It's a specific cluster of 3 physiological signs that represent the brain's last-ditch, often futile attempt to maintain perfusion in the face of sky-high ICP.
What are the 3 parts of the triad?
First, you get systemic hypertension, a significant rise in blood pressure. The brainstem senses that its own perfusion, CPP, is critically low because of the high ICP. So it sends out powerful signals to the body to crank up the MAP, trying to force blood into the head against the high ICP.
A desperate measure. What's the second part?
Bradycardia, slow heart rate. This seems counterintuitive with high blood pressure, right?
Yeah, usually high pressure means faster heart rate.
Not here. The hypertension triggers stress receptors, baroreceptors, in the major arteries like the aorta and carotids. These signal the brainstem to slow down the heart via the vagus nerve as a reflex response to the dangerously high systemic pressure. So you have high BP and low pulse occurring together.
The body is fighting itself.
In a way, yes. And the third component is irregular respirations. This can manifest in various abnormal breathing patterns like Cheyne-Stokes breathing or ataxic breathing. This sign indicates that the high pressure is now directly compromising the respiratory control centers in the brainstem, particularly the medulla.
So, hypertension, bradycardia, irregular respirations, Cushing's triad, a sign of impending disaster.
It's a very late and grave sign. It means the brainstem itself is under severe pressure and is beginning to fail. It often precedes or coincides with the ultimate mechanical failure of the system, intracranial herniation.
Herniation? That's when brain tissue actually gets squeezed out of place.
Exactly. When the pressure difference between compartments becomes too great, brain tissue is physically forced from an area of high pressure to an area of lower pressure, usually across those rigid dural folds or through bony openings like the foramen magnum. It's the physical consequence of the Monroe-Kelly doctrine failing.
What's the most common type? The sources mention uncal herniation.
Yes, tentorial herniation, specifically uncal herniation, is probably the most classically described. This happens typically when there's a large mass or swelling in one cerebral hemisphere, usually in the temporal lobe. This pressure pushes the innermost part of the temporal lobe, called the uncus, medially and downward, forcing it through that tentorial notch, the opening in the tentorium cerebelli where the midbrain sits.
So the uncus squeezes down alongside the midbrain. What does that compress?
It compresses several critical structures passing through that notch. This leads to a classic clinical triad of signs. First, the descending uncus often squashes the oculomotor nerve, Cien-Planck, right as it exits the midbrain.
Cranial nerve third controls pupil constriction and eye movements.
Right, so compression leads to paralysis of the nerve, causing the pupil on the same side, ipsilateral, is the herniating uncus, to become fixed and dilated. The classic blown pupil.
Okay, blown pupil on one side. What's next?
As the pressure continues, the herniating tissue compresses the cerebral peduncle of the midbrain. The peduncles contain the main motor tracts descending from the cerebral cortex.
So motor problems.
Yes. Usually the compression affects the peduncle on the same side as the herniation. But because the main motor tracks cross over lower down in the brainstem, this results in weakness or paralysis, hemiparesis or hemiplegia, on the opposite side, contralateral of the body.
Okay, so blown pupil on the side of lesion, weakness on the opposite side. What's the third part of the triad?
The third and most critical is compression of the midbrain reticular formation.
Mm.
This network of neurons is essential for maintaining consciousness and alertness. Compression leads rapidly to deteriorating level of consciousness, progressing to stupor and coma.
Blown pupil, contralateral weakness, coma, the uncle herniation triad. Very dangerous.
Extremely. It requires immediate intervention to relieve the pressure.
Are there other types of herniation?
Yes. Another common one is subfalcine herniation. This is when the cingulate gyrus, part of the frontal lobe near the midline, is pushed sideways under the rigid falx cerebri.
Under the partition between the hemispheres. Is that
It can be less immediately catastrophic than uncle herniation. Sometimes it's relatively asymptomatic initially. The danger comes if the displaced tissue compresses the anterior cerebral arteries, which run right along the falx. That can cause a stroke in the territory supplied by those arteries.
And the worst case scenario, the terminal event.
That would be central or tonsillar herniation. This is when pressure from above, or sometimes from swelling in the posterior fossa itself, forces the lowest parts of the cerebellum, the cerebellar tonsils, downward through the foramen magnum.
Down into the opening where the spinal cord exits.
Exactly. And right there at the foramen magnum sits the medulla oblongata, the part of the brainstem containing the absolute vital centers for controlling respiration and heart rate.
So tonsillar herniation compresses those centers.
Directly. It causes rapid cessation of breathing and cardiovascular collapse. It is uniformly fatal, if not immediately reversed, which is often impossible by that stage. It's the ultimate consequence of uncontrolled intracranial pressure.
A truly terrifying outcome. It really highlights how critical maintaining that pressure balance is, which all comes back to the brain needing that constant, reliable blood flow. Let's shift focus now to the supply line, cerebral circulation.
Yeah, understanding the blood supply is key because the brain is just so incredibly demanding metabolically.
The stats are pretty staggering, aren't they?
They really are. The brain is maybe only 2% of your total body weight, but it hogs about 15% of the entire cardiac output, the total amount of blood pumped by the heart each minute. And even more impressively, it consumes about 20–25% of the body's total oxygen uptake at rest.
Wow. For such a small organ, relatively speaking, why so greedy?
Because neurons are constantly active, maintaining electrical gradients, synthesizing neurotransmitters.
Yeah.
It's an incredibly energy-intensive process. And critically, the brain has almost no capacity to store oxygen or glucose. It relies completely on continuous delivery via the blood.
Which means interruptions are catastrophic.
Instantly. The saying time is tissue is nowhere more true than in the brain. Just 10 seconds of complete blood flow interruption, ischemia, is usually enough to cause loss of consciousness.
10 seconds.
And if flow isn't restored within a few minutes, typically 3 to 5 minutes, irreversible neuronal death or infarction begins to occur.
Okay, so where does this vital blood supply come from? The sources mention an 80-20 split.
That's a useful way to think about the two major arterial systems supplying the brain. Roughly 80% of the cerebral blood flow comes from the anterior circulation. This is supplied by the two large internal carotid arteries, ICs.
The ones that come up the front sides of the neck.
Exactly. They enter the skull through those carotid canals we mentioned. Once inside, each internal carotid artery typically branches into two main cerebral arteries, the middle cerebral artery, MCA, and the anterior cerebral artery, ACA. These supply most of the front and side parts of the cerebral hemispheres.
Okay, that's the 80%. What about the other 20%?
The remaining 20% comes from the posterior circulation. This originates from the two vertebral arteries, which run up the back of the neck, actually passing through little holes in the cervical vertebrae.
Okay.
These two vertebral arteries enter the skull through the foramen magnum and then fuse together at the level of the brainstem, specifically the pontomedullary junction, to form a single large midline artery called the basilar artery.
Vertebrals join to form the basilar.
Right. The basilar artery runs up the front surface of the pons and then typically terminates by splitting into the two posterior cerebral arteries, PCA. The posterior circulation, vertebrals, basilar, PCAs, primarily supplies the brainstem, the cerebellum, and the posterior and inferior parts of the cerebral hemispheres, like the occipital and temporal lobes.
So we have these two big systems, anterior, carotids, runi's, ACAMCA, and posterior vertebrals, the basilar, PCA. Are they completely separate?
No, and this is crucial. They are designed to be interconnected at the base of the brain by a ring-like network of communicating arteries. This is the famous circle of Willis.
Ah, the circle of Willis. I've definitely heard of that. It's like a traffic circle for brain arteries.
That's a pretty good analogy. It's an anastomotic ring. Anastomosis just means a connection between vessels. It links the anterior and posterior systems together.
How does it do that? What are the connecting pieces?
There are two main sets of communicators. First, there's usually a short anterior communicating artery, ACOM, that links the left and right anterior cerebral arteries, ACAs, at the front.
Okay, connects the two sides of the anterior system.
Yep. And then connecting the anterior system to the posterior system, you have the two posterior communicating arteries, PCOMs. Each PCOM typically runs backward from the internal carotid artery, or sometimes the MCA, to connect with the posterior cerebral artery, PCA, on the same side.
So ACA, COM, ACA at the front, and ICMCA, PCOM, PCA linking front to back on each side. That forms the circle.
Exactly. The full circle, in theory, consists of the ACOM, both ACAs, proximal parts, both internal carotids, terminal parts, both PCOMs, and both PCAs, proximal parts.
The whole point of this circle, this anastomosis,
Collateral circulation, redundancy. The theoretical function is that if one of the major feeder arteries, say, one internal carotid becomes blocked or severely narrowed, blood should be able to reroute through the communicating arteries from the other feeders, the other carotid or the basilar system, to supply the territory beyond the blockage.
like having detour routes available if the main highway is closed.
Precisely. It's supposed to be a safety net to prevent or minimize brain damage, stroke, in the event of a major vessel occlusion.
That sounds like a brilliant design. Does it always work?
Now here's the kicker. That textbook, perfectly formed, fully patent circle of Willis. Anatomical studies looking at actual human brains post-mortem or with advanced imaging have found that the classic textbook configuration is present in less than half the population, maybe only 30–40% in some studies.
Wait, less than half, so most people don't have the standard safety net.
Most people have variations. It's incredibly common. One or both posterior communicating arteries might be tiny, hypoplastic, or even completely absent. The anterior communicating artery might be missing or duplicated. One of the main arteries, like the ACA or PCA, might originate abnormally. There's a huge range of anatomical variants.
Oh, that seems really significant. If the backup system isn't reliably there.
It fundamentally changes individual risk. It means that whether someone suffers a devastating stroke from a carotid blockage or has minimal symptoms because collateral flow kicks in, can depend heavily on their specific individual anatomical variant of the circle of Willis. Their safety net might have holes in it or might be robust. You can't assume based on the textbook diagram.
That really underscores the importance of personalized medicine, maybe needing detailed imaging before certain procedures or to assess stroke risk.
Absolutely. It highlights that standard anatomy is often more of an idealized concept than a universal reality, especially in the vascular system.
Okay, before we get deeper into pathologies like stroke, there's one more protective element mentioned, the blood-brain barrier, BBB.
Yes, the BBB. Another critical protective mechanism, but this one operates at the microscopic level within the smallest blood vessels, the capillaries.
It's not just a physical wall, right? It's more complex.
Much more complex. It's a combination of anatomical features and physiological processes. The absolute key anatomical feature is the endothelial cells that line the brain capillaries. Unlike capillaries elsewhere in the body, which are often leaky, brain capillary endothelial cells are fused together by extremely tight junctions.
Tight junctions, like they're welded together.
Almost, yeah. These tight junctions severely restrict anything from passively diffusing between the cells, from the blood into the brain's extracellular fluid. There's also support from other cells, like astrocytes, which wrap their feet around the capillaries, contributing to the barrier function.
So it's a very selective gatekeeper. What does get through?
Small, lipid-soluble lipophilic molecules can diffuse fairly easily across the cell membranes themselves. This includes things like oxygen, carbon dioxide, alcohol, and anesthetics. Water also moves relatively freely via osmosis and specific channels.
What about essential nutrients like glucose? The brain needs tons of that.
Right. Glucose, amino acids, and other essential molecules can't just diffuse across. They require specific transporter proteins embedded in the endothelial cell membranes. These act like specific doorways, actively or passively facilitating the movement of only certain substances into the brain, the highly regulated transport system.
So the BBB protects the brain from toxins, pathogens, fluctuations in blood composition.
Exactly. It maintains a very stable, controlled chemical environment for the neurons to function optimally. It prevents circulating neurotoxins or neurotransmitters from the body, randomly affecting brain activity. It also keeps out most bacteria and viruses.
But this protection creates a problem sometimes, doesn't it? The dilemma mentioned in the outline.
It's a major therapeutic challenge. While the BBB is great at keeping bad stuff out, it's also incredibly effective at keeping potentially good stuff out. Many drugs, including a lot of antibiotics needed to treat brain infections like meningitis, or chemotherapy drugs for brain tumors, or even potentially helpful antibodies, are too large or not lipid-soluble enough or don't have a transporter, so they can't effectively cross the BBB to reach their target.
So the brain's best defense can also hinder its treatment.
Precisely. Finding ways to temporarily and selectively open the BBB to allow drug delivery without causing harm is a huge area of ongoing research. Things like focused ultrasound or designing drugs that can hijack existing transporters are being explored.
Fascinating challenge. Okay, let's tie all this together now by looking at system failure, the pathologies that arise when these protective and supportive systems break down, starting back with the meninges and those potential spaces. Bleeding problems.
Right. Bleeding inside the skull is categorized based on where the blood collects, which usually tells you the source of the bleeding. Let's start outside the dura. A bleed between the skull bone and the dura mater is an epidural hematoma.
Epidural. Epi meaning upon or outside the dura.
Correct. These are most often caused by trauma, particularly a fracture of the temporal bone, which tears the middle meningeal artery that runs in a groove on the inner surface of that bone.
The artery we mentioned earlier passing through the foramen spinosum.
That's the one. Because it's an arterial bleed, the pressure is high and the blood accumulates relatively quickly, stripping the dura away from the bone. This can cause rapid neurological decline and is often a surgical emergency.
Okay, that's epidural. What about bleeding under the dura?
That's a subdural hematoma. This occurs in the potential space between the dura mater and the arachnoid mater.
And the source here is different.
Usually, yes. Subdural hematomas are typically caused by tearing of the bridging veins. These are veins that cross the subdural space as they travel from the surface of the brain to drain into the dural venous sinuses.
Why would they tear?
They're vulnerable to shearing forces. Think about rapid acceleration or deceleration, like in a car accident or a fall, especially in older adults, where brain atrophy might put more tension on these veins. Because it's venous bleeding, the pressure is lower, and the hematoma might develop more slowly. It can be acute, rapid onset, or chronic, developing over days or weeks.
Okay, epidural, arterial, fast, subdural, venous, slower. What about bleeding into that CSF-filled space?
That's subarachnoid hemorrhage, SAH, bleeding directly into the subarachnoid space, mixing with the CSF.
And the source here?
This often involves the major cerebral arteries themselves that travel in that space. It can be caused by trauma tearing one of these vessels. But the classic cause of spontaneous SAH is the rupture of a cerebral aneurysm.
A weak spot ballooning out on an artery wall?
Exactly. Usually a saccular or berry aneurysm, often located at the branching points of the arteries in or near the circle of Willis. When one ruptures, arterial blood under high pressure floods the subarachnoid space. This causes a sudden, intensely severe headache, often described by patients as the worst headache of their life, along with signs of meningeal irritation. That's another neurological emergency. We can also have bleeding within the brain tissue itself and intraparenchymal hemorrhage, but these three, epidural, subdural, subarachnoid, are the main types related to the meningeal spaces.
Okay. Sticking with the subarachnoid space, besides bleeding, it can also get infected, right? Meningitis.
Yes, meningitis is inflammation of the leptomeninges, the arachnoid and pia mater, usually due to infection of the CSF within the subarachnoid space. It can be caused by bacteria, viruses, fungi, or other organisms.
And this inflammation causes specific symptoms.
Yes, the hallmark is meningeal irritation, or meningismus. This typically presents as a triad of severe headache, photophobia, sensitivity to light, and neutral rigidity, stiff neck, pain on trying to flex the neck forward. Fever and altered mental status are also common, especially with bacterial meningitis.
Diagnosis requires sampling the CSF.
Yes, definitive diagnosis usually requires a lumbar puncture, LP or spinal tap, to obtain CSF for analysis, cell count, protein, glucose cultures.
But there's a crucial safety rule here we touched on earlier related to ICP.
Absolutely critical. You must never perform an LP if you suspect the patient might have significantly elevated intracranial pressure due to a space-occupying lesion, like a tumor, abscess, or large hemorrhage.
Why not?
Because removing CSF from the lumbar sac suddenly lowers the pressure below the brain. If there's high pressure above, in the head, this pressure difference can cause the brain to herniate downward, particularly causing fatal tonsillar herniation. So a head CT scan is usually mandatory before an LP in anyone with neurological signs suggesting increased ICP to rule out a mass lesion first. Safety first.
Got it. Okay, let's move from meningeal issues to the major vascular catastrophes. Cerebrovascular accidents, CVAs, or strokes. Two main flavors.
Broadly, yes. The vast majority, about 80–85%, are ischemic strokes. This means blood flow to a part of the brain is blocked, leading to tissue death, infarction.
Blocked by what?
Usually either a thrombus, a clot that forms locally within a cerebral artery, often on top of atherosclerotic plaque, or an embolus, a clot or debris that travels from elsewhere, like the heart or carotid arteries, and lodges in the smaller cerebral artery.
And when that tissue dies,
Yeah.
that's the stroke deficit we see.
Yes, but there's a crucial concept here, the penumbra. When a vessel is blocked, there's typically a core area of brain tissue that dies very quickly due to severe ischemia. But surrounding this core, there's often a region, the penumbra, where blood flow is reduced but not completely absent. The neurons here are dysfunctional but potentially still viable if flow can be restored quickly.
So the penumbra is salvageable tissue.
Potentially, yes. That's the main target for acute stroke therapies like thrombolysis, clot-busting drugs, or thrombectomy, physically removing the clot. The goal is to reperfuse the penumbra before it progresses to irreversible infarction. Time is absolutely critical. The penumbra shrinks over time.
Okay, that's ischemic stroke. What's the other main type?
Hemorrhagic stroke. This accounts for about 15–20% and occurs when a blood vessel within the brain actually ruptures and bleeds.
We talked about aneurysms causing subarachnoid hemorrhage.
Right, that's one major type of hemorrhagic stroke. The other main type is intraparenchymal hemorrhage, IPH, which is bleeding directly into the brain tissue itself.
What causes those?
The most common cause is spontaneous IPH, especially in deep brain structures like the basal ganglia, thalamus, pons, and cerebellum, is chronic hypertension, high blood pressure. It weakens the walls of small penetrating arteries, like the lenticulostriate arteries, making them prone to rupture. Other causes can include bleeding disorders, tumors, or vascular malformations like AVMs, arteriovenous malformations.
And the damage here is twofold. The bleed itself plus the pressure.
Exactly. The leaking blood damages tissue directly, and the accumulating blood clot hematoma acts as a rapidly expanding mass, causing increased ICP and potentially leading to herniation, just like we discussed with the Monro-Kelly doctrine.
Okay. To bring this home, let's connect these vascular events back to the specific anatomy. How does blocking a particular artery lead to specific functional problems? This involves the brain maps, the homunculi.
Absolutely. The neurological deficit you see after a stroke depends entirely on which artery is blocked and therefore which part of the brain loses its blood supply. We can predict patterns based on the known territories of the major cerebral arteries and the functions localized to those areas, often visualized using the motor and sensory homunculi.
Let's start with the anterior cerebral artery, ACA. Where does it supply again?
The ACA mainly supplies the medial inner surfaces of the frontal and parietal lobes. Think about the motor and sensory strips. The part representing the leg and foot lies right on that medial surface, dipping down into the longitudinal fissure.
So an ACA stroke would affect the leg?
Predominantly, yes. The classic deficit is contralateral, opposite side, hemiplesis or hemiplegia, weakness or paralysis, that affects the leg much more severely than the arm or face. They might also have sensory loss in the leg.
Any other ACA signs?
Because it supplies medial frontal regions involved in judgment, inhibition, and bladder control, ACA strokes can sometimes cause personality changes, impaired judgment, and urinary incontinence. If the dominant hemisphere's supplementary motor area is hit, they might have a motor non-fluent aphasia.
Okay. Now, the big one. The middle cerebral artery, MCA. Most common site for strokes.
By far the most common territory for ischemic strokes. The MCA has a huge territory, supplying most of the lateral convexity of the hemisphere, large parts of the frontal, temporal, and parietal lobes. This includes the primary motor and sensory cortex for the arm, hand, face, and throat, as well as the major language centers in the dominant hemisphere.
So an MCA stroke deficit would look different from an ACA stroke?
Very different. The classic MCA stroke causes contralateral hemiparesis and sensory loss that affects the face and arm much more significantly than the leg. This is sometimes called a brachiofacial predominance.
Because the face and arm areas are out on the lateral surface supplied by the MCA?
Exactly. You also often see contralateral homonymous hemianopia loss of the same half of the visual field in both eyes because the optic radiations pass through the MCA territory.
And language.
Critically important. If the stroke affects the dominant hemisphere, usually the left, MCA strokes are the classic cause of aphasia. Depending on the exact location, it could be Broca's aphasia, non-fluent speech, good comprehension, Wernicke's aphasia, fluent but meaningless speech, poor comprehension, or global aphasia, severe impairment of both, if the entire territory is affected.
What if it hits the non-dominant hemisphere?
Then instead of language problems, you're more likely to see issues with spatial awareness, attention, and perception. Classically, hemispatial neglect, where the patient fails to attend to or recognize stimuli on the side of space opposite the lesion.
Okay, ACA, leg, arm, face, MCA, arm, face, leg, plus language neglect. What about the posterior cerebral artery, PCA?
The PCA, remember, comes off the basilar artery and supplies the occipital lobe, responsible for vision, and the inferior and medial parts of the temporal lobe involved in memory. It also supplies deep structures like the thalamus.
So PCA strokes mean vision problems.
Primarily,
Yep.
yes. The most common deficit is contralateral homonymous hemianopia, similar to MCA strokes, but often without macular sparing, meaning the central vision is also affected. If both occipital lobes are affected, e.g. by a basilar artery occlusion, it can cause cortical blindness. The eyes are fine, but the brain can't process visual input. You can also get complex visual processing problems like visual agnosia, inability to recognize objects, or prosopagnosia, inability to recognize faces.
And memory.
Yes, if the medial temporal lobe structures like the hippocampus are involved, PCA strokes can cause significant memory impairment. If the thalamus is hit, it can cause contralateral sensory loss, or sometimes bizarre syndromes of spontaneous pain, thalamic pain syndrome.
Okay, that maps the major arteries. What about that special case, the watershed stroke?
Watershed or border zone infarcts. These occur in the areas between the territories of two major arteries, like between the ACA and MCA, or the MCA and PCA. These regions are like the end of the line for perfusion from both sides.
So they're most vulnerable if overall blood flow drops.
Exactly. They're most susceptible to hypotension, systemic low blood pressure, maybe after cardiac arrest or severe blood loss. When the overall pressure driving blood flow is low, these distal border zones don't get adequately perfused from either side.
And this causes a specific pattern of weakness.
It can cause a very characteristic pattern, sometimes called man and barrel syndrome. The watershed area between the ACA and MCA often corresponds to the motor cortex controlling the proximal limbs, the shoulders and hips. So patients develop weakness in their shoulders and hips bilaterally, while their hands and feet remain relatively strong.
Like, they can move their hands and feet but can't lift their arms or legs properly, as if stuck in a barrel.
That's the image, yeah. It really highlights how the precise location of circulatory failure dictates the functional outcome.
It certainly does. We've covered a huge amount today, from the protective skull through the suspending meninges and buoyant CSF, the critical pressure dynamics governed by Monroe-Kelly and autoregulation, the high-demand blood supply with its complex circle of Willis and BBB gatekeepers, and finally, the devastating ways this system can fail through bleeds, infections, and strokes affecting specific territories.
It really is an incredibly intricate and dynamic system. Seamless when it works, but with stark consequences when any part breaks down, because every component relies on the others functioning perfectly within very narrow margins.
And we kept coming back to that idea of anatomical variation, particularly with the circle of Willis, that theoretical safety net. We learned the textbook version is actually, well, not the norm, present in less than half the population.
Which really makes you think, doesn't it?
It does. So here's the final thought for you, our listener, to ponder. Given that this crucial circulatory backup system, the circle of Willis, varies so significantly from person to person, with the ideal form being relatively uncommon, what does this inherent anatomical variability truly imply about individual risk? How much does our unique plumbing determine whether a vascular insult is minor or catastrophic? And looking forward, how might neurocare need to evolve beyond relying on standard textbook diagrams to develop more personalized approaches, predicting risk and planning treatments based on an individual's actual specific neurovascular anatomy?
Something to definitely mull over.
Yeah.
The standard human is perhaps more varied than we often assume.
Indeed. Thank you for joining us for this deep dive.